Good morning, everyone. My name is Yeondong Kim from the Department of Anesthesiology and Pain Medicine at Jeonbuk National University College of Medicine and Hospital. Today, I will present a policy analysis on chronic pain management gaps within Korea's community integrated care system and propose a practical solution, the Public Health Center Linked Pain Care Model, which we call PHC. South Korea officially became a super-aged society in 2025, with over 20% of the population aged 65 or older. This figure is projected to reach 30% by 2036. In response, the government launched the Community Integrated Care Initiative in 2018, designed to help other adults aged in place. However, there is a critical blind spot. 4 of the 10 most prevalent diseases among Korean elderly are musculoskeletal conditions, and MSK disorders account for 12.9% of all chronic disease expenditure, actually exceeding cancer. Yet, chronic pain is systemically excluded from the CIC framework. When we look at the three service domain of CIC, the pain care gap becomes clear. In the health and medical domain, visiting nurse monitor blood pressure and glucose, but there is no standardized pain screening tool and no referral pathway. In the welfare domain, services like meal delivery and housekeeping address functional consequences, but the root cause, musculoskeletal pain, is left untreated. In transitional care, patients discharged after spinal surgery receive no continuity of pain management, leading to readmission. The critical point, chronic pain, is absent from all 4 core CIC domains. This gap has direct consequences of poor older adults as health consumers without a trusted public care pathway. 3 patterns emerge: doctor shopping, repetitive visits across multiple clinics for non-covered procedures, rising out-of-pocket costs from unverified alternative therapies, and ultimately premature nursing home admission as unmanaged pain errors daily function. These are not just clinical problems, they represent a systemic failure of health consumer protection. The scale of this problem is substantial. Korean population data show that 72.6% of adults over 65 have low back pain. In the closer cohort, 62% reported pain, back pain being the most common. Most critically, individuals with severe pain had nearly 3 times the odds of ADL impairment compared to those without pain. The pathway is clear. Untreated pain leads to functional decline, which increases welfare dependency, which creates nursing home placement. PHC is designed to intervene and break the cycle. Our proposal model, PHC, operates through 3 sequential phases. Each directly addresses one of the gaps we identified. Phase 1 is screening. Phase 2 is referral, and Phase 3 is follow-up. Importantly, this model requires no new infrastructure. It builds on what already exists. In Phase 1, visiting health nurse and a brief pain screening to their existing home visit checklist. Currently, they check blood pressure, blood glucose, and 6 other health behaviors, but pain is absent. We propose adding a BAS score and identification of the problem pain site. Any patient with BAS or 5 or higher occurring 3 or more times per week is registered as an intensive pain management target in the National Health Information System. This is a simple operational addition. Let's see Phase 2. Phase 2, we establish a formal referral network. The Public Health Center signs an MOU with the Regional Medical Association to designate participating clinics as community pain safety clinics, prioritizing pain medicine specialties. Patients on the intensive management list are transported to CPSCs using the existing CIC care taxi service. After treatment, for example, lab blocks, pharmacological adjustment, a standardized feedback form is returned to the public health center, closing the referral loop. Three enabling elements make this work: the MOU framework, care taxi logistics, and PHIAC integration. Page 3. Shift the focus to sustained self-management. PHC health promotion staff deliver education on correct analgesic use, pain relief stretching, and fall prevention. Visiting nurses continue periodic bus monitoring. The goal is to move older adults from passive recipient of framework care to active self-managers, reducing unnecessary repetitive procedure and sustain the functional gain achieved in phase 2. The anticipated benefits operate at 3 levels. At the individual level, access to evidence, base pain care with the public system, reducing doctor shopping. At the system level, restoring ADL function, reduce welfare service demand and delays nursing home admission. At the macro level, reducing premature long-term care placement directly relieves pressure on national health insurance and the long-term care insurance fund, both under significant fiscal strain. We acknowledge that this study is policy analysis based on secondary literature without pilot outcome data. Future research should include pre-post evaluation of BAS score and healthcare utilization following VHMP pain screening introduction, as well as formal cost-effectiveness analysis. A pilot MOU program at a regional public health center would be the ideal next step. This is conclusion. To summarize, the gap is real. CIAS systemically exclude chronic pain. PHC is feasible, no new infrastructure required. And the impact is triple: individual, system, and physical. As I close, I leave you with this: successful aging in place demands that the chronic pain recognized as a core public health priority. Thank you for listening. This is Kim Yeon-dong.